Hi, my name is Dr. Courtney Adams, and I am the VP of Clinical and Medical Affairs at Aerobiotics. Joining me today to discuss the importance of air quality in the operating room is Dr. Michael Decker, an orthopedic surgeon at the University of New Mexico. Thank you for joining us today, Dr. Decker.
I appreciate it, Dr. Adams. Thanks for having me.
So, Dr. Decker, while there are already several existing guidelines and regulations regarding air quality during surgery, what specifically led you to place an additional focus on improving air quality in your OR?
Yeah, so I think early in my career, when I came to the university, one of the issues I wanted to address within my own operating environment was really how do we control all the factors that might lead to potential increased patient risk. That's where a lot of my attention was early on. And I had the opportunity to meet from some members of the aerobotics team during the American Association of Hip and Knee Surgeons meeting, which is the first time I actually got to see the Alluvia unit, the aerobotics Alluvia unit. When we talk about controlling the operating room environment, certainly, like you said, there are a lot of current existing regulations for general OR airflow, but what is happening in that specific case, that for that specific patient at that very moment, can be highly variable dependent upon a number of factors. Who's in the room? How many people are coming in and out of the room? Which direction are they coming in and out of the room? How are they moving through the room? What kind of potential contaminants do they carry in with them? Where did they come from? So I think there's all these other factors that, though we have some general rules, we have to be very focused on that microenvironment that is the operating room with the patient in it. And the potential risks that come with that. So that's where my attention was initially. Associated with that was my concern about potential infection rates. I know that's a goal of all joint surgeons and all surgeons really, is to minimize, if not completely eliminate, infections in your operating room. And I felt like maybe we were at a place where we had a significant room for improvement. And this was my first opportunity to try to tackle that problem. So that's what first brought my attention to this particular issue.
So after meeting with us, what changes did you implement to work towards that goal of improving air quality?
Yes, I think the initial changes we tried to focus on were a lot of low-hanging fruit. How do we control room traffic to start? I think there's plenty published on the potential risk of increasing room traffic, on the impacts it has on airflow patterns, and just generally on a potential introduction of contaminants from the outside environment into the room. But tracking that is somewhat difficult depending on your resources. So we began focusing our attention a little bit on that. When I had the opportunity to bring in the Alluvia unit for the first time to really begin assessing our air quality, I had the opportunity to work with some members of the team who helped me track those measurements, both the amount of traffic in and out of the room and the associated changes in our air particle counts. And I was fascinated by the numbers. The reduction in particle counts in the air was almost 80% compared to when the unit was off in the room. And that was somewhat dependent upon the number of times the door was opened during the case. So that was one of the first things we tried to focus on was we have to really address the basics of reducing airflow abnormalities in our operating room to reduce the risk of potential contaminants in the air. So that was some of the things we tried to focus on initially.
So after bringing the Alluvia into the room, and like you said, having the opportunity to visibly measure the air contaminants in the room, do you know what were some of the outcomes of implementing that change and having that data available?
The best part about that was having that data, because I think when we talk about air quality in the OR, it means something. We can associate it with a lot of potential risk. But it's hard to then translate that into something that makes sense for all the different members of the team that have and play a role in controlling that. And so it's easy to come to your team and say, hey guys, I really need to reduce room traffic. I really need to make sure that people in the room are wearing jackets. I need to make sure there's less people in the room. That's easy to say, but helping the team understand why that matters is somewhat difficult. How does it matter to them? When I can take to them a number that says, hey, when we control those factors and turn this unit on, we have an 80% reduction in contamination in the air, that's something they can attach to and say, wow, that's really important. That's really meaningful. And so that is the most important thing I think we were able to bring to them is this is real data. This is something you guys can control. Let's work on controlling that. And I think we have seen some significant improvements, both behaviorally and outcome-wise because of that.
You mentioned being able to really implement that behavioral change. Did you see any reduction in surgical site infection at your site?
Yeah, for us, so again, I'm relatively early in my career, but the advantage of that is I also, we try to pay very close attention to these numbers early on as we're trying to modify our practice. So we found, at least initially, with a combination of increased air filtration in the room, combined with adding some of these behavioral changes, especially associated with room traffic, within my own practice, about a 50% reduction in surgical site infections, which is a huge jump. So we were really proud of that number. We hope to continue to see that drop as we use the data we're getting to focus on those changes.
It's really impactful. Beyond protecting patients, do you believe that there are any additional benefits to improving air quality in the OR?
I do. Speaking of low-hanging fruit, we talk a lot about environmental exposures when it comes to the workplace in general. And we talk a lot about the potential risks to people in the operating room. And there are some members of the operating team that have to undergo certain type of health screenings before they even begin their employment. But we don't all have to, and surgeons certainly don't have to. We don't talk a lot about the potential risk of increased noise in the operating room for hearing loss or air contamination on patient or people and patients who have potential risk factors. So I think there's a significant opportunity for improvement in air quality as it pertains to both the patient and the staff in the operating room. And by staff, I really mean we have circulating nurses, scrub techs, anesthesiologists, CRNAs, assistants, physician's assistants, potentially residents or fellows. There are so many other people in this room except for the surgeon and the patient, and they may have potential risk factors for complications associated with poor air quality, such as asthma, pregnancy. There's a number of potential issues there. So I think it's really important that we start thinking about this not just as a patient risk issue, but as a operating team risk issue.
Well, as a final question, I would ask you, do you have any advice for other healthcare providers who may be wanting to drive change to improve air quality at their own site?
Yeah, I think one of the benefits of what we have had a chance to do here is really see objectively in real time what the impacts are of a number of variables on the OR air quality. The introduction of the Alluvia Sense unit has helped us see in real time specific events that are occurring in the operating room that are impacting that air quality. And that is something we can now tie an objective value to. I know exactly the level of volatile organic compounds in the air when we open a cement vial. I know what happens when we don and doff our gowns in certain directions and what impact that has on the air around the operating environment and a number of other issues. So I think we have this objective data that we can use in real time. And I think when you're talking about implementing change with your healthcare team, the most important thing you can do is bring everyone to some type of common goal and common ground. And sometimes you have to learn to speak the language of those people you're trying to work with. And there are things that matter to some people that may matter less to others and vice versa. So bringing some data to the table, some real-time data to the table and say, this is what we're trying to fix. And this is why it matters for the patient, but also why it matters for you and why that might matter for your team can be really impactful. And that I think is going to gain you a lot more buy-in from your team and a sense of collective ownership for everybody in the room, including the patient and the staff. So that's probably the most important thing I would say is use this data to help you bring the entire team to the same table.
Dr. Decker, I'd like to thank you so much today for giving us your experience and your insights. And again, we just want to say thank you and we appreciate your time.
Yeah, thank you so much for having me. I appreciate it.